Muchas gracias, Juan, por tu excelente presentación. Y ahora tengo el honor de invitar a la doctora Jacqueline Palace, quien es la jefa del Servicio de Esclerosis Múltiple y de la Clínica de Espectro NMO en Oxford. Claramente conocemos que es una pionera en este tema y hoy tenemos el gusto de contar con ella para lo que tiene que ver con tratamientos actuales y manejo de la enfermedad relacionada a MOG. Muchas gracias, doctora. Adelante.
So I'm going to cover the current treatment and management of MOG antibody disease. And my disclosures are set out on this slide. So it's worth rehearsing some important differences between MS, aquaporin 4 antibody, and MOG antibody disease to understand why we treat MOG-AD as we do. So in MS, the relapses are mild with good recovery and very little disability accrual, and the majority of disability is related to the progressive phase. And in contrast, in aquaporin 4 and MOG antibody disease, all the disability is relapse related. Therefore, we focus very much on relapse treatment and prevention. And both of these conditions have severe relapses. But the difference is that there is poorer recovery in aquaporin 4 antibody disease than in MOG antibody disease. And therefore, there is more disability in aquaporin 4 antibody disease. The other important feature is that there is a monophasic and a relapsing phenotype in MOG-AD. So here I have put up figures from a UK incident cohort, a French incident cohort, and I have aligned the axes to be similar. And what this shows is that most of the relapses occur early on, and then it appears to flatten off. Around 45% of patients will relapse in the first 2 to 3 years. And to reiterate that not all patients with MOG antibody disease will have a relapse, so there are monophasic forms. So there are 3 important treatment considerations in MOG-AD. There's firstly treating the acute attack. There's secondly reducing these early relapses, as I showed you. And then thirdly, in those patients who have relapse in MOG-AD, preventing further relapses. So if we start with the acute attacks. So I said that they recover much better than in aquaporin 4 antibody disease, but it doesn't mean that all patients recover fully. So here we have outlined the different phenotypes at onset and the percentage that recover. And in white, there's full recovery, grey, there's good recovery, and those in red with poorer recovery. And you can see that all phenotypes will have a percentage of patients with less than good recovery. Between 10 and 40% will have this poorer recovery depending on the onset attack, with LETM, bilateral optic neuritis, and patients with the MMO phenotype, optic neuritis with transverse myelitis, perhaps doing worse. And here we have the age of onset with the same outcomes. So we have less than 20 on the left, in the middle, 20 to 45 years, and then on the right, those patients over the age of 55 at onset. And if you look at the white, you can see that full recovery is much more likely to occur in young onset disease and less likely as patients present at an older age. Again, going back to the UK cohort and the French cohort, we can see that the median disease duration in the UK cohort was slightly longer, at 28 months versus 11 months. But if they both looked at EDSS outcomes, and in the UK cohort, about 5% of patients were EDSS 6 or greater at this follow-up. In the French cohort, it was 12%, and an EDSS of 3 in a higher percentage, 22%. However, these higher percentages may be related to the fact they excluded those with optic neuritis at onset. So this was a concentrated cohort. If we look at the visual outcomes, so both these similar visual outcomes, less than 6/36 or less than 6/30. In the UK cohort, you can see that 16% had poor visual outcome in at least one eye, 3% were bilateral. In the French cohort, I believe their outcome was unilateral, didn't actually say, and it was 6%, so that's less. And actually, this was just from those patients who presented with optic neuritis at onset. They did have a shorter follow-up time. But it's important not to forget the sphincter and sexual dysfunction that can occur from the transverse myelitis attacks. So nearly 30% of the whole cohort in the UK group had permanent bladder dysfunction. The majority of these were from the onset attack, and 17% used long-term catheterization. That's a large number. And if you look at the males with a transverse myelitis onset, 3/4 of them had significant bladder dysfunction. About 20% had bowel dysfunction, and a similar number of males had erectile dysfunction. And if you look at the males that had a transverse myelitis onset, it was much higher, 44%. These outcomes are not well represented in the EDSS score, but they're very important, have a big impact on the quality of life. We look at the attack recovery from the onset group. Here we have set out a percentage that did poorly, had poor recovery from the onset attack. This is a follow-up. It clearly demonstrates that there's much poorer recovery in Aquaporin 4 antibody patients than in MOG antibody patients. But what is interesting throughout the whole group, including the MOG antibody group, is that ever smokers has a much worse outcome than those who never smoked. So I think this is important when discussing these factors in patients. So this is why we treat the acute attacks just as urgently and as aggressively in MOG antibody disease as we do in Aquaporin 4 antibody disease. We treat with high-dose intravenous levopregnisolone, and if there's a poor response or they've got bad disability, we promptly bring in second line, either plasma exchange or IVIG, or more IV levopregnisolone. So now I want to come on to trying to reduce those early relapses or rebound attacks as I'm just discussing them today. So here's some data that demonstrates that the time to relapse from the onset attack might depend on the length of time you cover them with follow-on prednisolone after the acute attack treatment. And what you can see here is a shorter course, less than a month or 1 to 3 months. The patients are much more likely to relapse than if they have a longer course of 3 to 6 months or 6 months. But of course, these two groups are actually on steroids for some of this period of time. So what it's worthwhile doing is looking at what happens when they discontinue the steroids. And what you can see is that this effect is retained. There is still a steeper drop-off in those with the shorter courses of prednisolone than those with the longer courses. You can see that those who have greater than 6 months seem to have less of a drop-off than those with 3 to 6 months. And so because of this, we treat our patients with 6 months of oral prednisolone to reduce these early relapses. If the MOG antibodies are still present, we may cover up to 12 months with very low dose prednisolone if they can tolerate it. This is from an Australasian study where they looked at the effects of reducing prednisolone and the length of time they used prednisolone and when they stopped it. And what they showed here in the red, the patients that relapsed as the prednisolone dose was taken down. And you can see that the majority of the relapses tend to kick in when the prednisolone dose is reduced from about 5 to 15 milligrams. But the vast majority of relapses actually occurred when prednisolone was stopped and had been stopped in the first 5 months. So this does suggest that MOG antibody disease is very steroid sensitive. This is a questionnaire that was sent to a number of NMO experts internationally to see how many of them used corticosteroid taper for more than 3 months after the onset of attack. If we look on the adult side here, we can see that about a third of them said usually or always they use more than 3 months, and 2/3 sometimes or always or usually. Very different pattern in pediatric neurologists, where a small number actually said usually, and about 50% said never. So there does seem to be a difference. So now we come on to what we do if patients with MOG antibody disease have a relapse, and we want to try and therefore prevent further relapses. Here is the algorithm that we use for Nmosd. Prednisolone, and it can be and or with steroid-sparing agents, the classic azathioprine, mycophenolate, methotrexate, or rituximab. And any of these combinations are used in different centres, and if they relapse, having been given an adequate dose for an adequate length of time, then you need to change the treatment, either increase the dose if there's scope to do that, add on, or use an alternative first line. We now, of course, have 3 new therapies for Nmosd. We have satralizumab, nebulizumab, and eculizumab. And then we have the fallback options of some of the older immunosuppressive agents sometimes used in other antibody conditions, such as cyclosporin or tacrolimus, tocilizumab that has been used, and other anti-CD20 agents. But what do we know about the effects of some of these therapies in MOG antibody disease? So here's a retrospective analysis from the French cohort, and what they've done is they've grouped together what they call type 1 immunosuppressive therapy, meaning azathioprine, mycophenolate, or Ritux, and looked at time to relapse. And these are all relapsing MOG patients. They weren't treating monophasic patients. And they compared time to relapse compared to those that received no treatment, and there was a significant effect with a hazard ratio of 0.4. If you look at the different treatments and compare them against each other, they are small numbers, and you look at the annualized relapse rate reduction compared to the pre-annualized relapse rate, and when they're on it, you can actually see that there's a largest reduction with mycophenolate, with very similar effects with the azathioprine with the TUX, and in fact the MS disease modifying drugs. However, if you look at the percentage that were relapse-free, you can see here that mycophenolate and rituximab had the highest effect, azathioprine a second at 54%, and then the worst outcome at only 22% of MS patients were relapse-free. It is important to note, however, that they had a longer follow-up. This effect clearly mirrors quite closely what we would expect to see in outcome for antibody disease. 2 more retrospective analyses, one from an Australasian study of 59 patients with relapsing MOG-AD involving children and adults with a median follow-up of 45 months, and a pediatric study with a larger number with a longer median follow-up time. So what we can see here, this is the relapse-free percentage. By far, the most effective appeared to be prednisolone. Very few patients had relapses. Then rituximab came in at second, and then IVIG and mycophenolate very similar, around 43-44%. A very different picture, though, from the pediatric study, where came in top at IVIG. There was a longer follow-up that might explain the higher relapse rate. Azathioprine and mycophenolate similar, and worse, rituximab. So there's a bit of a difference between the rituximab and the IVIG relative effects. It may be that IVIG is more effective in children, it is used more frequently in children. So there have been a lot of anecdotal discussions about patients breaking through on rituximab. And so the Liverpool team got together from a number of international sites, 121 patients with MOG antibody disease who've been treated with rituximab. They were able to show, and perhaps not surprisingly, that there was a greater reduction in the relapse rate if we used it first line, 63%, versus if used at second line. And that's not surprising. And you can see here that you relapse much more quickly if you use it second line than first line. I've put on this slide data from use of rituximab first line in Acrine 4 antibody disease from South Korean cohort. And again, I've adjusted the axes so they are similar and comparable. And what you can see is if you overlay the effect, rituximab appeared to be more effective in Acrine 4 antibody disease than in MOG antibody disease, with the caveat that these are completely different populations. So there's just a hint. There's a smaller case series, but a very neat case series from the French group, looking at what happened to some of their Acrine 4 patients versus their MOG patients when treated with rituximab. What they showed was about a quarter of their Acrine 4 patients relapsed, the mean follow-up of 38 months. Many more, 38% of their MOG patients relapsed within half the time. Of particular interest is that the vast majority of their Acrine 4 antibody patients relapsed only when the CD27 count started to recover, when their B cells started to come back. Whereas the opposite was seen in MOG antibody disease, when the vast majority of relapses occurred when the CD27 count was still suppressed. So this may be suggesting that those long-lived plasma cells that produce the antibodies, maybe they're longer lived in MOG antibody disease than Acrine 4 antibody disease. That's one potential explanation. So coming back to MS treatments. So I showed you earlier that in the French group, only 22% of their patients that were on MS disease-modifying therapies were relapse-free, much less than in the other groups. So this is from pediatric cohort. There are 52 individual patients shown here. And you can see that all the circles in the left figure are relapses. And there's a lot of purple circles. And these are interferon-related relapses. And if you look over to the right, join together all the patients on interferon or glutaminyl acetate, and the relapse rate before treatment and on treatment is really no different. So it doesn't seem to be having any effect at all. And the EDSS score before and then on treatment, if anything, tends to go up in some of the patients. So it does appear that the MS drugs may not work for MOG antibody disease in the same way they don't work for Acrine 4 antibody disease. There are some important pediatric considerations. So there probably is a lower rate of rebound relapses or early relapses in younger children. And there are worries about using corticosteroids because the effect they have on growth and on weight. So generally, the pediatric neurologist will use a shorter post-relapse prednisolone wean, and that might explain that questionnaire that I showed you earlier, the difference between pediatric and adult neurologists. When patients develop relapsing disease, they tend to use less prednisolone and more steroid-sparing agents. They have a lower threshold to try IVIG. And in those patients with relapsing MOG-AD who are on immunosuppression, they remain relapse-free. Maybe they tend to retry coming off immunosuppressants sooner to see whether the children can cope off immunosuppressant agents. And this is nicely set out in the paper reference down below. So you'll probably be aware that the new Nmosd treatments have been shown to be effective in randomized controlled trial, as shown here. There's satralizumab, which is a monoclonal against IL-6 receptors. There's inebilizumab, which is a monoclonal against CD19. And there's eculizumab, which has a monoclonal against complement. What do we know from the randomized controlled trials? Well, there's some data from aquaporin 4 antibody negative disease. So I set out here on the left satralizumab add-on study, on the right the satralizumab monotherapy study, and at the top the effects in those that have aquaporin 4 antibodies, and in the bottom those that don't. And within these, one would expect to have a mix of true antibody negative and maybe some MOG antibody patients. what you will see in the Aquaporin 4 antibody group is that there is a big treatment effect with marked reduction in relapses in those on satralizumab compared to placebo. But in the bottom, there really isn't a treatment effect that can be seen. In the inebilizumab study, there was only 17 patients that were negative for Aquaporin 4 antibodies. 13 were randomized to the active arm and 4 to placebo. There were no relapses in these 4 placebo patients. There was 1 relapse out of 6 MOG patients and 2 relapses out of 7 true antibody-negative patients. And in the eculizumab study, all patients had Aquaporin 4 antibodies. So actually, from the randomized controlled trial, I don't think we can say very much about whether these drugs will work in MOG antibody disease. So let's speculate. Will the anti-CD19s work better than rituximab? So on the right here, you've got that diagram I showed you earlier. And on the left, it's to remind you that CD20 is expressed on the B cells, this is the B cell lineage, but not on the plasmablasts or on the long-lived plasma cells. CD19 is expressed on plasmablasts. And so by knocking out the plasmablasts as well, you may have 2 effects. Firstly, it's more downstream to the long-lived plasma cells. And so anti-CD19s might work quicker. But also, if it knocks out the plasmablasts, it may actually affect some of the MOG antibody producing cells immediately. So yes, there may be a theoretical reason why anti-CD19s may work better than anti-CD20s, even more in MOG antibody disease than in Aquaporin 4 antibody disease. Will the anti-IL-6 receptors work in MOG antibody disease? So here's some measures of IL-6, which is a pro-inflammatory cytokine in the CSF. And here you can see controls. MS patients, interestingly, in MS, IL-6 is not elevated, and very similar elevated levels in both MOG and Aquaporin 4 antibody disease. So I think it might be worthwhile considering anti-IL-6 receptor agents to try out in MOG antibody disease clinical trials. And finally, will anti-complement agents work in MOG-AD? So again, this is to remind you that Aquaporin 4 exists in 2 isoforms, the M23, shown here, and this form clusters and forms orthogonal arrays, and then the monovalent form below, M1. And we know that clustered antigen will allow antibody to cross-bind, cross-link, and this is much more efficient in activating complement. And because MOG is monovalent, it is likely that antibodies binding to it are not going to be that efficient at activating complement in theory. Here we have the serum levels from the study, C3 and C4, and normally these will be reduced in active complement activating diseases. What this shows is that normal range, normal controls are here in black, and that both these are reduced in Aquaporin 4 antibody disease, but actually, if anything, elevated or normal in MOG antibody disease, and these were taken during the onset acute attack. Here is an experimental model injecting MOG antibody with complement directly into mouse brain. And what they're able to show is that there was marked complement deposition with Aquaporin 4 antibodies, but not with MOG antibodies. It was just faint complement deposition. And below this, they showed that whether you injected MOG antibody on its own or with complement made no difference to the demyelination that was seen. So the demyelination effect of MOG antibody in this was not dependent on complement. And then when we come on to the human studies, pathological studies, complement deposition is pronounced in Aquaporin 4 antibody disease, and it is not in the MOG antibody disease pathology. So this will suggest that anti-complement agents may not be very effective in MOG antibody disease. So that's my speculation. So in summary, we treat the acute attacks urgently and aggressively. I think it's useful to advise patients to stop smoking. And it probably is helpful to give patients a prednisolone taper over months. How long, whether it's 3 months, 6 months, or a bit longer, I think is an individual decision. But after the onset attack, probably a shorter course in children, this is the practice. Longer term immunosuppression is not indicated after the onset attack, i.e. in monophasic disease. But standard immunosuppressive therapy does appear to have an effect in relapsing disease. Rituximab appears to be less effective than for Aquaporin 4 antibody disease. Maybe the consequences of the MOG attacks are much less than for Aquaporin 4 antibody disease. And therefore, I think a trial of immunosuppressive therapy after a relapse-free period is an option. And we would never do that for Aquaporin 4 antibody disease. We don't take patients off treatment. I think some, but not all, of the new Nmosd therapies may work in MOG antibody disease, and this needs further clinical trials. And there are many other potential therapies that are being developed for other autoantibody disease that I think would be worth trying in MOG antibody disease.